Hello, everyone. Hopefully you can all join and see this webinar. I'm Samir Shah. This is my first webinar at Qure. This is the first webinar I've done since joining Qure about 3 weeks ago. So I'm really excited to be here and so glad you guys can all join us. I am here today with two of my colleagues in thoracic radiology, Cal Clark and Jay Sohn. I'm actually not going to do introductions for them. They're going to do their own. I'm just going to give you a little background on myself first. I have a long history in teleradiology. I was at Nighthawk originally and in leadership there. Went to VRAD for many years. Subsequently, joined the team at Matrix at Rad Partners for many years. And then I most recently was Chief Clinical Officer at Envision Healthcare. And now I'm joining Qure to hopefully usher in a new age of AI for my fellow colleague radiologists. So I'm really glad everyone's here. We're going to have a great discussion on lung cancer, AI, and we're going to cover a bunch of different topics, some of them eclectic, but I think it'll be an entertaining hour for everybody. So, Cal, I'm going to hand it to you first to give an introduction on who you are and even some of your AI background, if possible.
Great. Thanks, Samir. Yeah, so my name is Cal Clark. I'm a ER radiologist at University of Texas Health San Antonio, also our vice chair of informatics. And a lot of my research interest and my interest in AI is in kind of making our jobs easier, making us more efficient. So I've done a decent amount of work in perception and decision, kind of safety analyses, a little bit of radiogenomics, and then really kind of diving into the large language model landscape. So really excited for today's talk.
Hi, I'm Jay Sohn, assistant professor in cardiothoracic imaging at University of California, San Francisco, UCSF. I'm also a co-chair of education at the Center for Intelligent Imaging at UCSF that focuses on leveraging big data and data science techniques for radiology in general. My area of research is in lung cancer imaging, and thankfully I was one of the early introducers to the field of big data and AI through my master's degree in statistics, and then by virtue of interacting with engineers in the Bay Area. So I was able to form a team of engineers and physicians during my residency time, and eventually carried on to form my big data laboratory. We focus on lung cancer imaging from screening point. Who are the people who will be eligible and who should be screened more intensely? How do we risk stratify pulmonary nodules? How do we do patient level risk stratifications? And how do we extract useful information out of lung cancer screening CTs and chest x-rays? These are some of my core interests that leverage big data. And additionally, I do some clinical projects and translational projects, translating novel imaging modalities like low-field lung MRIs and doing radiological report processing. So I'm really excited to have this conversation today with you all.
Yeah, so am I. Interestingly, all three of us trained at different places. Jay, you trained at UCSF. Cal, you trained at Duke. I trained at UPenn. And all of them are kind of leading the way in AI and doing some unique things, even when it comes to thoracic radiology. So I think all three of us will have a different perspective on how we are approaching AI. One of the things I want to start, basically, we all know lung cancer is one of the leading causes of death. It's treatable, it's curable, and we know that screening is a good thing to do in high-risk patients. But about 15 to 20% of patients who have had no risk factors for developing lung cancer may develop lung cancer. Should we expand screening in this day and age of AI and nodule detection and very advanced CT? Could we do more? Is there something we can do to expand screening? I'm going to hand it to Cal first, and then Jay. Jay, I know this is your area of interest, so
So I think in terms of expanding screening, there's kind of one way to approach it. We're always trying to do this risk benefit trade off for radiation, and for cost. Some interesting parts. So, in AI, you have this kind of image-based AI and tabular-based AI, and tabular just means basically text. I think as we move forward, what we're going to see is that we can further refine who is at risk for lung cancer, so that even where we're sitting right now and saying this is the population that qualifies for lung cancer screening through different genetic tests or different like demographic factors, environmental factors, we'll be able to kind of refine that down and say, here's an additional population that would qualify. And then you get into this aspect of imaging is being utilized more and more, especially as we start to employ physician extenders into the decision-making process. There's research that shows that cross-sectional imaging goes up. What's happening is that kind of everyone is getting this kind of lung cancer screening as just part of normal clinical care. And I think the radiology practice discipline hasn't really decided kind of how to deal with those incidental nodules. And from an ER perspective, a lot of the time I'm getting ER scans that are like for trauma. And so this idea of like doing lung cancer screening on those trauma CTs isn't really front and center of my mind. And so it doesn't really get into that same kind of workflow of going through a specialist and kind of a thoracic radiology. And it's more like, is this patient going to die? And so that's what we're finding is this mismatch between what kind of information do we need to communicate immediately to the clinicians, and then what's all the other interesting stuff that is in this scan, because we're basically doing like a virtual living autopsy of a patient every time they get a CT scan, and these CT scans are just chock full of data, which I'd be happy to talk about. But I think that's kind of like how to frame a good way to frame the discussion.
Agree.
Yeah, I think, Kyle, you talk about a lot of interesting and very relevant topics in lung cancer screening. But going back to Samir's original question regarding expanding the screening criteria, there's certainly a lot of effort, not just in radiology, but pulmonology, oncology, and primary care literature about risk-based stratification of patient-level risk stratification and using that to qualify. But the reason we currently have the USPSTF criteria are based on several large randomized control trials, with the most famous one being the NLST trial completed in 2011 that showed 20% lung cancer specific mortality reduction with low-dose chest CTs in that population that meet the smoking criteria and age criteria. So to deviate away from that requires additional level of evidence. But we can actually learn a lot from our breast imaging colleagues, where there's an even longer history of screening, where they actually have this high-risk screening program that involves alternating MRIs and mammograms in 6 months interval with more intensive screening based on their risk models. And I think where AI can really come into a lot of play is setting up that risk model. What predicts a person's risk of having lung cancer in addition to smoking history? And we already know certain demographics, population in East Asia or women with very, very famous elevated incidence of lung adenocarcinoma. And then there's also those with family history of lung cancer, and those who are living in certain polluted area of the world who may be at higher risk of lung cancer as well. So the discussion is still ongoing, and I expect that in the next decade, possibly in the next couple of years, there may be large-scale trials that are completing to expand this criteria. And in that place, I think AI will play an important role to identify these high-risk individuals.
Well said. Does that include like the genetic markers that Cal was mentioning? Because I agree with you that the incidence of lung cancer is much higher where in the third world, where there's a lot of pollution and air quality isn't so great. It's going to cause metaplasia, et cetera, et cetera. We can see logically, but is there any kind of genetic marker that might make somebody predisposed?
There's EGFR markers and I think ATK markers. There's family of mutations in those markers that are pretty well known and very high risk for lung cancer, but they're very rare around the world. Yeah. In most cases, I think the consensus right now is, why is there such high incidence of lung adenocarcinoma in certain ethnic population? They suspect that it's at least epigenetic, if not genetic, but there's no identifiable one genetic focus that's been identified in those population. So that's been the tough part.
Yeah. One of the things I'll say is that Okay, so just a little background and things I've learned in 3 weeks at Qure. You know, Qure is the most adopted AI in the world, and it developed its strength from TB. TB is the #1 infectious disease killer in the world. We don't think about it much here in the U.S., quite frankly, just because of the prevalence is so low. But one of the things Qure did that I had never really heard about before was partner with pharma and industry, and basically, I can tell you that it's actually shown some very 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 good scientific rationale that if we use AI, find TB cases, and actually treat sooner, we're actually saving people's lives. Um, this might be something we should do in the U.S. Especially as AI develops a capability to tell you, more on a radiomics line, like what is this nodule actually sensitive to based on its morphology or some black box features that we don't even know. Just putting it out there as an interesting kind of thing, because that's one thing that we haven't really thought about. And this question of who's going to pay for AI always comes up in the US. Is it going to be the insurers? Is it going to be the PAC systems? Is it going to be the radiologists? Is it going to be the health systems? So this was a new concept for me, and I think it's very, very interesting.
Yeah, I think this is this is actually a really great point, because we have I think we've been operating under a very kind of path heavy classification of disease with the WHO criteria, and this is kind of blends into an area of radiogenomics, looking at brain gliomas, which was my area of interest and residency and fellowship. And this idea of are these kind of categories actually the real categories for how diseases kind of express themselves and how to kind of approach treatment? And this idea of radiogenomics is that genomics is half of the equation, and
Exactly.
the actual morphological appearance that may not even really be perceptible to humans, that humans may not even
Right.
really be able to describe, is actually really important to kind of further differentiating these. And then once you further differentiate, this is the whole concept of personalized medicine, or like hyper personalization of medicine, is that each like disease process is slightly different, needs a slightly tailored approach. So as we start to kind of incorporate these larger analytical capabilities with AI, now we can start to say, okay, maybe the problem with some of our disease treatment regimens weren't the actual regimens themselves; they're just not targeted appropriately. We didn't have enough refinement of our diagnosis or diagnostic capabilities. And once you change that, then all of a sudden now things that may not have worked before, they actually do work, but they only work for a small subselection.
Yeah, and one key limitation of pathology is always the area that we're sampling, because when we are biopsying these nodules, for example, we're only taking, say, 5% of the entire volume of the nodules, and we're extrapolating to the entirety of the nodules, and also what's surrounding the nodules that's outside in the normal lung parenchyma. So that becomes a challenge. And in the cases of surgery that actually take out the entire nodule, maybe we can actually look at the entire thing. But cases of subsolid nodules, early neoplasia, pre-neoplastic lesions are key interest to my team, as well as entire field of lung cancer diagnostics and imaging and treatment. And I think there, radiology, and especially radiomics and AI, could play an important role. How do we know which one of these pre-neoplastic or early neoplastic lesions eventually progress to a full-blown cancer versus the cancers that people die with rather than die of? That's one example of area that radiomics could play an important role. And certainly there's many granting agencies both within NIH and lung cancer organizations that are focusing on this topic, both in the form of imaging, as well as there's also liquid biopsies, blood-based biomarkers, in addition to pathology. So most likely it's going to be a multimodal approach where radiomics plays an important role too.
It's a great point about the biopsies. I'm an interventionalist in a former life, and I'm in Pittsburgh, PA, and I worked in the VA system, et cetera. And yeah, it happened a lot. A growing nodule, pet avid nodule comes back, negative, and it's not. We sampled the wrong area. We sampled the necrotic core or something that is giving a false result. So no question about it. Very good point. So okay, I'm going to shift gears a little bit, and I'm going to change the topic. What, what, whose responsibility? Okay, first of all, the background is I'm older than you guys, and I come from a background when we actually assumed that lung cancer screening was actually not going to be an issue. Everyone thought there were going to be too many incidentalomas, and nobody ever thought there was going to be lung cancer screening. The way I kind of think about things is that if we're overwhelmed with nodules, even back then, I thought to myself, if we're overwhelmed with chasing nodules that are not going to turn out to be lung cancer, we're going to be doing a disservice to patients, et cetera. But chest CTs are very, very good at finding nodules, unlike plain mammograms, et cetera. So how is AI going to help us track and follow these nodules better than we can do it? Think of the average rank and file radiologist out there. It can be very difficult to even find all the nodules given the time pressures we have with the amount of crushing volume we're all under. So how do you guys view AI helping us?
Yeah, I think this is when I'm looking at different AI technologies, maybe I'm always have difficulty with rib fractures just because there's a lot of them. But I think pulmonary nodules is actually the more impactful area here for exactly the reasons that you mentioned. The pulmonary nodule is this kind of neoplastic process that's a three-dimensional process. And so I'm going to kind of make the 2D versus 3D kind of argument here, where the 2D assessment of a nodule is kind of a consequence of convenience, where it says like, okay, it's very hard for a radiologist to kind of have an accurate perception of what this three-dimensional structure looks like. And so this is something that I see is that measuring something in 2D, looking at its maximal area. Those sorts of things have inherent inaccuracies into them. And so how can you even really kind of attack this problem of prognosticating what this nodule is going to do when you don't accurately describe its volume? So I'm really interested in this kind of 2D area versus volumetric assessment. That's just like out of the gate. Then you get into this process of accounting and bookkeeping of these nodules over time in a dynamically moving structure like the lungs, which is a technical challenge. And so I see a lung nodule AI as kind of having two main thrusts: accurately describe the nodule in volumetric dimensions, and then keep track of it over time to get an accurate assessment of its doubling time to start to prognosticate. Mm-hmm. It's just like it's a very interesting technical problem that I think is much easier with other lesions.
I absolutely agree with Cal in the idea of using AI and just IT platform in general to keeping track of these nodules and doing some advanced processing. Because when AI and these advanced IT image processing is not involved, we're essentially taking a look at the nodule and just putting some calipers on there and getting a sort of qualitative idea of what is the risk of these nodules. And there's inherent subjectivity and variability in that process. So we want to use AI to more objectively analyze these nodules, both in radiomics or even just putting a caliper on there. We can be a little bit more consistent among readers. And then the idea of what to do about these nodules and risk stratification, of course, will be helpful with more data. If you think about the most famous guidelines that are out there, LUNGRADS as well as Fleischner Society guidelines, these are actually based on only several thousand nodules or maybe tens of thousands of nodules. And if you look at it, we're using those guidelines plus our individual radiologist's personal review of nodules. Maybe I know I've seen about thousands of nodules, tens of thousands of nodules, and using those to essentially do a modeling in our brain to see this risk of this nodule is going to be maybe 20% chance of cancer. But there's an opportunity in which if an AI is really tracking all these nodules and assembling millions, tens of millions of these nodules and keeping track of them, how they're changing, we have an opportunity to really improve the field and say, well, these nodules based on database of 1 million nodules that there's no way one radiologist or even one paper can identify, it knows that this has 22% chance of being cancer. I think that's an opportunity to significantly contribute at a larger scale to the entire radiology and patient community of lung cancer.
Great answer. I will tell you, Cal, we're both emergency radiologists. I love rib fracture AI, and my rads love rib fracture AI. But like for most radiologists, I actually agree. I think pulmonary nodule AI is huge, and if it's done really well and accurately, I think it's great. You know what I see now, and again, when I'm going to say this, I'm talking about really good, experienced radiologists. They don't have time to put calipers on anything anymore, and they just look, and they're like, I know that's 3 millimeters, I know that's 6 millimeters, and to me, I'm like, okay, that's dangerous because our eyes are not always perfect. Calipers are always kind of better, but it's still 2D. And quite honestly, I've been guilty of it myself. Let's just like look at a nodule and I can see. But we're talking about a dynamic structure, the lungs, and then the other problem is that um, we tend to look at the most recent prior, right? Because
Yeah,
of our
exactly.
PAC systems. It's the same thing in plain film. I think it's a weakness that we just kind of look at one X-ray. Like the old days when I was there, we hung films on an alternator and you'd look at 4 days and you'd just see the ICU progression of a patient. And you'd be like, oh, this is what's happening. And here's the bottom line. It's getting better. It's getting worse. I see the waxing and waning because every different positioning of the patient, affects what you see on a day-to-day basis. Is that effusion getting bigger, smaller? So I love the fact that we used to look at 4 or 5 days of plain films. The same thing for CT. Oh, how's this head bleed progressing over 4 days? How's it progressing over 4 different scans? Same thing with the nodule. But you guys know we're just comparing to the most recent one, which may have been done 3 months ago, and there's like no change, no change, no change. But you look at it from 2 years ago, and wow, it's a slow growing malignancy.
Right.
That's why I think AI is really good. Okay, so that's my little rant. But the next question is tracking and AI and follow up. First of all, whose responsibility is it? Is it our responsibility as radiologists to kind of improve the system? Or is it the pulmonologist? Or is it the hospital that should be, kind of instituting a navigator to track nodules? I just want to know your opinions because there's a lot of different AI-based companies popping up that are going to help with follow-up programs and care coordination. And pulmonary nodules is one of those things that they're really, really touting because it's just much more full-formed than other things that we do. Have at it. Go ahead, Cal.
Yeah, I think it's really interesting because you get into this when you have a lung cancer screening navigator tool. You got to look at, okay, who is this going to, which department, which segment of your workforce is this going to impact the most, for better or for worse? So I think I would frame it as there needs to be, whichever module has the greatest need in the current state needs to kind of be the decision maker. And so if it's a problem with, lung cancer follow up, with getting patients to kind of come in back for screenings, for follow-ups, then I think you have to go there. At the same time, I think you have to give the radiologist the option to kind of veto certain tools when it's like, this is onerous, like we cannot do this. This is just unworkable. And so that you get into this, I think that's probably like the structure I would think about it. And that's why the domain champions from the radiologist side, from the nurse navigator, and the hospital kind of leadership all needs to be on the same page for this to kind of do an impact assessment to say, are we staffed to do all this? Where it's like, oh, the like radiologists, they'll put it in, like they'll do all this. And so yeah, you really have to kind of look at it from, are we staffed? Do we have the resources? Is there enough emphasis put into the setup and the training so that everyone knows how to do this? Because like I think a lot of times we just put the onus on radiologists to become kind of IT experts in new software. Right. And part of my research and like perception and kind of how radiologists respond to new software products is that this is like a very disorienting process to them. And when you start instituting changes to how they do their search patterns, and you and kind of inject this new perturbation into it, you lose this kind of like 10,000 example competency that you develop, and you basically start over. And you introduce a lot of risk to the patient when you're kind of introducing a new thing. So I think that's how I'd frame it.
Right.
Yeah.
I would just quickly say that, like, you're right. It's that, like, I have to say it's not Samir Shah using the new technology, because, you know, I'll use it, I'll follow the rules, I'll do it. It's the other radiologists. It's a radiologist, you know, who are at your system but are in the community. How are they going to use all this stuff? And change is bad, you know, because we fall into our patterns in order to keep patients safe, you know, so that we don't change things and miss things. Go ahead, Jay.
Yeah, it's a battle between, I know, keeping the status quo to make sure, because it's stable, right? And we know whenever there's a change, there's going to be some perturbation and some risk to patients that happens. So I think it's always weighing the balance between these two. And I'm sure, being a clinical informatics person and in this field, this is probably going through your mind, and you're doing this calculation all the time, making sure this is the right change. Regarding who is responsible for the communication, I think there's a legal answer and practical answer, and perhaps what is the right thing to do answer. I think legally, if it's a suspicious nodule, then I think by medical legal standards, I think radiologists are required to communicate those things to our clinicians, has been where the jury or the law stands. Practically, what happens is for a successful lung cancer screening program, for our institution, I think the San Francisco VA is a really successful program that's running. They actually have a nurse practitioner, a nurse, and a pulmonologist director of lung cancer screening who's carefully following these patients and running these programs to ensure that nobody's actually dropped off, and if patient is not responding, they follow up. So that type of program is, I think, practically what's done in many institutions, and I would love to hear if there's any different arrangements. I think in some ideal situation, I can think of a IT innovation in which these nodules are sort of kept track by our radiology department's IT section, and then that's actually facing both primary care doctors and patients. And if there is no sort of a follow-up that's being done as recommended, then automatically kind of investigating and perhaps recommending what's happening and closing the loop in communication. So I think that may actually make things really efficient.
Yes, I agree. And I will tell you from my perspective, Jay, so if you want to know, again, most of my history is in national groups, private equity-backed groups, so that, like, I have this perspective and see how this group does it, that group does it, this system, this healthcare system does it. And you're right. The way that you described it, the San Francisco VA, is probably the right way to do it. I mean, that's a very meticulous way of getting things tracked. And I've seen, like, the best of these nodule tracking programs and care coordination is like augmenting those people. That I don't think we're ready for full AI tracking, etc. But like, if you can take a nurse navigator and if they can follow 40 or 50 in a day, and you make that 5-10 times that amount, now you can actually handle a large number of incidental findings, not even just nodules. And that's what healthcare systems want. That's what patients want. That's what we want. So that's just my background from a large national scale. That's the way to do it. Obviously, it's being led by the academic centers too. Go ahead.
And I guess the thought is here's that because there's lots of cool AI techniques, especially in behavioral change and behavioral modification. But at the same time, it's like are we even to the point of even talking about that when just being able to detect which patients have not even gotten an appointment scheduled for follow-up, and how many nodules have been incidentally detected and the primary care physician doesn't really know about it. There's kind of, we have this real asymmetry in how these nodules are kind of managed. And so, some institutions will have these nurse navigators, and then other institutions, basically have nothing. And how do you, I think a lot of tools can be deployed at each segment for each of those different, those populations. I think it's really interesting. But I just wanted to mention, like, the behavioral modification of, patients responding to copays and patients responding to different
Oh
types
yeah.
of messages is really interesting as we start to predict, predicting no shows, predicting all these different types of things. Calling in a patient to say like, hey, you need to come in for your follow up is going to be treated much different than, hey, you have X percentage risk of cancer. We need to bring you in for your screening. Your screening is scheduled for X date, compared to just say you need to schedule your appointment. Vastly different
Exactly.
changes. So you
X
almost
percent risk. Right.
it's
Yeah.
almost it's a psychology. It's like half psychology, half medicine.
Right. Because what's a nurse navigator going to do when, a nodule which would fulfill Fleischner criteria for something, but, the radiologist says, follow up as clinically warranted or something
Right.
like that,
Right.
right?
Yeah.
That happens a lot, even in 2023. Again, you guys are somewhat protected at academic institutions from this, but I see a lot of different things happen out in the community. And so I think it's key and important. Okay, we're at the half-hour mark, and I just want everyone to know I'm seeing all the comments in the chat. There's some great questions. I'm going to address them all, but we have a nice full hour to discuss a whole bunch of things. So we're gonna address everything. Okay, so here's my next question. Cal and I are teleradiologists. I have seen, this shortage of radiologists is quite severe. And in my day, I would just tell clients, do not send any screening CT to telerad. It's just not going to be seen on our list. Because at the time it was new. It was like you had to make sure the patient did X, education for smoking cessation. You had to make sure that the radiologist fulfilled criteria of reading X number of scans a year. You had to also, make sure the protocol was done properly. And believe it or not, in some of the early days, people were not even doing the simple lung cancer screening protocol correctly. Now, I know we're in a different day and age, but I'll tell you, now we see a lot of screening CTs on telerad's lists, A, and B, post-COVID, we have a lot of remote readers out there that are supposed to be reading routine studies, are supposed to be reading daytime studies, and maybe at home during the day, and we don't know their capabilities for doing it. Are they going to use lung rads, et cetera? How would we tackle that issue? Because like I was loath to do them, and quite honestly, I've totally changed my opinion. I'm like, yep, Telerad has to learn how to do this. I want to hear from both of you guys on this.
Yeah, Jay, you want to tackle this one first?
Yeah, that sounds good. Certainly, I think lung cancer screening CT has capability of incredibly increasing volume. I think I was just reading through the chat, and some of the comments mentioning only 15 to 20%, or only small portion of patients actually getting lung cancer screening CT. So volume can go up significantly. I think AI has a very important role to play in both educating perhaps general radiologists who might not be as familiar with lung cancer screening CT, to sort of remind them if there's discrepancy, then they can look up the evidence and see which way to go in terms of lung rads, and potentially speeding up the workflow. However, I think at the moment the evidence and our experience with AI stands where at least for myself, I'm not comfortable having AI just read the lung cancer screening CT on its own and then trust that it's found all the nodules and then trust that result. I usually have to do the exact same amount of work and in addition look at the AI. So it's in a phase where it probably slows me down, but improves my accuracy. But I think over time, as AI gains the trust and confidence of the radiology community, I think it can potentially really help in terms of speeding up the lung cancer screening CTs and potentially allowing us to read more of those. And especially in teleradiology practices that have these AI solutions that's well integrated and well vetted, I think can make a lot of difference.
Cal, I'm going to let you answer, but I just want to comment on what Jay said. Yeah, we can't afford to slow down a radiologist like by a second, right? Like if we do, they reject anything, right? But like somebody like you or Cal are thinking long term. You're thinking this is slowing me down right now, but I see the benefits. I think with technologies like ChatGPT and transformers, et cetera, imagine what you could do to improve follow-up recommendations, right? Like even NLP would be able to, take a description of a nodule and say, hey, this is the appropriate Fleischner guideline for this nodule, or if it doesn't fall into Fleischner, it falls into X, Y, or Z scientific literature-based follow-up. It could also easily convert a teleradiologist emergency dictation at 2 a.m. into a pulmonology-focused lung rads impression too. So that's like crazy stuff that we're thinking about, and I'll talk about this. We still have some time, but okay, back to you, Cal.
Yeah,
telerads
yeah,
and these.
yeah. One of my interests is in malpractice economics, and I think this idea of teleradiology companies basically being able to disclose their conformance rate for stuff like lung rads and these kind of criteria or communication of findings, I think is going to kind of give practices a lot of confidence to say, like, maybe sending these studies out to someone that's done a ton of lung cancer screening CTs and has this documented rate of X is actually what we want, because what's going to happen is internally they're probably not going to have those numbers, and so now you're trading this unknown factor internally of I don't know how much conformance I have with my thoracic radiologist versus
Right.
here someone as a hyper specialist. So I think that's one answer, and then I think the second answer is that we're getting into this area where it's always kind of weird in radiology, where you have a totally normal chest CT get 0.8 work RVUs, and then you have this lung nodule that's very difficult. It's a peculiarity of radiology, where in the entire rest of medicine there is this kind of graded levels of complexity, and you get paid more if it's more difficult.
Right.
So I kind of see that that's a potential new area for AI to kind of say, like, yeah, we're going to start reimbursing you appropriately for complex cases compared to easy cases. And so then this idea of I think people get burned out, and people and practices struggle with the internal politics when it seems like one person's doing more work than the other one, and people don't feel appropriately compensated. And some these lung nodule cases are difficult, and so if I can read a trauma CT, trauma chest versus a chest with a bunch of nodules, and I get reimbursed for the differential, it's like, okay, that's fine. I get reimbursed accurately. Right now, I don't think that's there, and I think there's some of that kind of undercurrent that's happening in this debate.
Mm-hmm. It's a great point.
One additional comment. Sorry.
Yeah. No.
One additional comment I have is that arguably reason for teleradiology and general radiologists to read lung cancer screening CTs, there's some level of protection in terms of risk stratification, because ultimately the final adjudication happens with the multidisciplinary tumor board. And I think, if I recall correctly from the NLST trial and many of the lung cancer screening program, they either require or strongly recommend having at least some sort of a tumor board adjudicating, not just a radiologist. So as long as a radiologist is able to identify some level of suspicion of nodules, I think there is protection.
Good point. I also like your point, Cal, on reimbursement. I can tell you it's no secret that reading a PE CT angiogram with 4,000 images is actually easier than reading a lung cancer screening CT with multiple nodules. We all know that, and you're going to get paid more for the PE study. So it is ironic. Okay, so I want to ask a question. We also have plain film AI. Plain film AI is a huge part of Qure's portfolio. There's no question there's been years of advance in plain film, and one of the things that we can do really well is find nodules on plain film. Given what I see, I've again, I hate to harp on the same theme over and over, but like, radiologists are pressed for time. We tend to treat plain films like a secondhand child, or here a stepchild here, because we're always focused on CT. Is there a role for what do you guys think of plain film detection of nodules? I think it's great, because I think we miss nodules all the time. And again, AI, it's not human vision. It's sometimes we can perceive things that we won't perceive. an overlapping shadow doesn't mean anything to them. To AI, AI can determine what's a nipple shadow and what's a nodule. All these different things that AI sees, quote unquote, that we can't see. So, what are your thoughts on that?
Yeah, this is something that we actually tested with a Japanese data set, which basically contained I think around 400 or 500 path confirmed lung nodules for lung cancer, and then graded them based off of their difficulty in perception. And what we did is we're a big eye tracking lab, and basically just watched faculty and residents try to parse through these. And it is very difficult for these kind of intermediate difficulty nodules to be detected by faculty and residents. And so I think we're used to on chest CT where it's either there or it's not. The conversation gets a little tougher for radiographs for the reasons you mentioned. So I think as a chest radiograph being a screening exam, so trying to prioritize sensitivity, I think there is this role of AI to kind of backstop that process and say, yeah, we may have a high false positive rate, but this is a screening exam. That's its job. The area that I'm really interested in is, what do you do when now you're kind of like having to double read every single chest radiograph, and chest radiograph is the most popular by far. And this is some of the pushback that I've gotten, and I think we're seeing new studies come out. It's like, does AI potentially slow you down if not implemented correctly? It's like, okay, so I have to look at the chest X-ray once, then I have to look at the chest X-ray again for the kind of the AI opinion. So yeah, I think there's some technology innovation that needs to happen with, like, how do you deal with that so you're not slowing people down, but you're also getting the benefit of the sensitivity. I think it's an open area of discovery.
It's always a balance between that, like increasing diagnostic accuracy, but you have to review one more image, which can be quite big in chest X-rays, where we're only spending maybe 1 minute per chest X-ray, or sometimes even shorter. And right. I think some potential breakthrough right now in large language model could be at least one. That's not a complete solution, but one solution, in the sense that I think more and more companies are now offering full dictation of chest radiographs as if a resident has already dictated these reports. And in that report, one could include a red flag, as well as description of the nodule that it identified. And if it's a relatively, assuming that it's high quality report, then just like a resident's preliminarily dictated report can be helpful, I think it could potentially speed us up in that we don't have to hold the dictaphone and dictate. The other component that needs a little bit more innovation, that I think is not completely researched at this point, is comparison across time, because comparison of chest radiographs is so important to accurately reading these cases, especially for inpatients or ED cases or others. So once those two innovations of large language model based generative NLP dictating the reports, plus accurate comparison can be made over time, including those of CTs perhaps, and PET CTs and others, I think there is a growing minority, it's still a minority, but growing minority of thoracic radiologists who believe that perhaps all the chest radiographs could be actually pre-dictated by AI at this point, and also red flags properly issued. And then all that the radiologist needs to do is basically thumbs up or thumbs down, saying, is this okay, is this not okay?
I think that's where we're heading, no question, because I think it would actually improve quality, right? Like I think I've got a long-term perspective, having, been in this game for a long time, and I definitely think that our interpretations on plain film sucks, because generally we are trying to get through them as fast as possible. We're not looking for subtle things. And I trained back in the day where, like, the attendings would tell you what the patient had for breakfast, right? Because we had to be better than the pulmonologist that was going to come down into our reading room, and basically, we had to be better than them on interpretation of plain film. And that was how we added value, was to be really, really, really intellectual about our evaluation of plain film. That's gone, right? And what you mentioned, Cal, about eye tracking is very important, because I've actually studied some of this as well. Even when you're looking at your pattern for looking at nodules can be different than looking for fracture or any pneumothorax or something like that, right? So pattern matters a lot in terms of finding things. And it's not as sexy, right? Plain film is not as sexy as CT, but it's still the majority of imaging in the US. It's, more than 50%, slightly more. And it's, everyone thinks it's not sexy until there's a malpractice suit for a missed nodule, because, and Cal, you and I know at 2 a.m., you are going to try to find that referring doc, or even call the patient if you have to, just to make sure, or check on it 2 days later if at 2 a.m. you see a mass in an outpatient X-ray that you happen to read, in the telerad stack. So I think it's important. Okay. We have some questions in the chat. I think one interesting question was, if AI applications add images to studies on PACS, what happens if someone may act on it before it's reviewed by a radiologist? Who is liable? It's an interesting question for me, because I think that what we're going towards more and more is also like communication apps. And should AI be democratized? Like, why should only the radiologist get something? And what if we're still behind and we still delay 40 minutes on a large vessel occlusion, when somebody else might be able to act on it much faster and should be mobilizing the patient much faster? And obviously this is how like response teams come about, even PE response teams, for pulmonary embolus. It's important. Time is important to all treatment, and we know time is brain. But like, how should that, who's ultimately liable? I'm always, my perspective, before you guys answer, is always like, it's up to us. It's like, if there's a new mouse, we're still responsible for the report. It's our name on the report, and AI is a tool, just like a mouse or a keyboard is a tool. So
Oh yeah,
go ahead.
I think there's two things here. One is the complete AI dictation versus the kind of like the augmented additional image that's put in front, that's added to PACS, that says, here are areas of suspicion, here's what I think it is. And yeah, for the complete AI dictated report, that's going to be, I think, on the radiology department to kind of vet and to kind of have those discussions and be like, here's sensitivity, here's specificity for these different solutions. For the kind of like additional image aspect of where a lot of AI companies now are kind of adding this kind of explanation or AI generated kind of image where it'll say like, look at this area, like this area is suspicious, or here's a fracture, here's maybe a fracture. This is an area I'm really interested in because we already have like in orthopedics, sometimes they don't even look at our reports. They're just dictating it on, just looking at it by themselves.
Sure.
And then in the ER is a very interesting thing is happening because there is this kind of push and pull of ER clinicians getting additional reimbursement if they can bill at a higher level of care if they interpret the film themselves.
Yeah.
And if you imagine the ER physicians all on a spectrum, and I think this is a kind of a microcosm of the entire healthcare system, is that there are some people that feel comfortable dictating radiology films on their own, and then others are like, I'm going to wait for the radiologist to dictate. And I think this is a new area that's still untapped. Is like the biggest users of radiology AI may not in fact be the radiologist. And in terms of revenue generation, having your ER docs all of a sudden now be essentially kind of prelim radiologists that can all bill at that higher level of care. And it's not just for nothing. Now they can triage and they can say like, okay, I feel confident. We start to move this knowledge median of this distribution of comfort, of radiology comfort, further and further to where radiologists are. And I don't think that sort of economic analysis has been done yet on like what happens when now all your ER providers are now high level of care billers for radiology studies, and you get more money and your patients get out faster. It's kind of a win for everyone.
Good point. I think in that area, one question becomes: does that mean radiology does not get reimbursed? Is one. It sounds like radiologists still probably put in the final dictation afterwards and get reimbursed. Is that correct?
Mm-hmm.
Right. And I think the idea of who's responsible in the cases of acting upon AI. My guess, I don't know the medical legal answers for this, but it sounds to me like it's something that if a clinician decides to bypass radiology read and then just solely rely on AI, they would be the ones responsible. And my guess is I have a lot of trust in our clinical colleagues, at least in our system, and they probably would not just look at the AI and blindly trust and then move forward. And they must be reading on their own and using AI to essentially add confidence to their own read and making sure that they agree with it and feel comfortable moving forward is going to be my guess.
Should we let them even see the AI, or should we say, hey, you guys are too dumb to understand, area under the curve, and you don't we'll tell you what the final result is. Like historically, every time radiologists have kind of done that, we have failed. We have done a terrible job. So I'm interested to hear what you guys think.
Yeah, I think medical imaging is such a powerful diagnostic, quick technology that we cannot. It's not even practical to gatekeep it. I think one of the watershed moments for me is when my sister was in a nursing class, and she was like, "Oh yeah, we're doing radiology modules of like how to interpret imaging," and I'm like, "What?" And this is just such an important aspect of clinical care. We see this all the time where we're adjusting, we're recommending adjustments to the endotracheal tube. We're commenting on pneumothoraces, et cetera. You call a clinician and be like, "Yeah, we know. Yeah, thanks for the heads up."
We already shot the repeat film, right?
yeah, exactly. Yeah, so I think and we're seeing a lot of point of care imaging, and I think we're in this cool position where this is such a good technology that people are learning it, and that was my comment earlier. It's like people are learning this. How are they learning it? And I think AI has a role here, and so that's one way that I've been advocating approaching health institutions and says, like, this is not just for radiology. Like, your clinicians need this tech. How are they learning this? Who's teaching them? And this kind of on the job simultaneous training that you can get with kind of an AI augmented report. It's functioning in a diagnostic role, and it's also functioning in a teaching role where there's no real substitute that exists right now.
Yep.
Yeah, I think the gatekeeping idea doesn't work, and I don't think we're able to gatekeep this. And I think just ethically too, if this can actually improve patient care, we need to be an advocate of clinicians seeing these images. The only cases that I can think of that may be problematic is if the AI is of questionable quality. And then in that case, we, at least in our cases of AI integration, we have for AI software that's not been really well vetted, we shied away from even putting those images on PACS and just look at them on different separate like an internet browser, and then only if we agree, then we put them in.
Gotcha. Definitely agree. Yeah, my niece is a medical student, and when she was in her first year, gross anatomy was just intertwined with radiology, cross-sectional imaging, et cetera. And I went to med school I was doing gross anatomy in the early 90s, and there was just nothing, and it's amazing to see, and gatekeeping just never works.
Right.
We have 5 minutes left. I want to ask you both kind of what do you see coming. We know a lot of technology is going to be developed in 10 years. What's going to happen in the next 5 years? Where do you think that AI is going to go in terms of lung cancer and patient care? I'll tell you my opinion, but I'd like to hear from you guys first.
Yeah, JD.
So we already talked about everything,
Well, I think 5 years is pretty quick. So one obvious thing is, despite this AI revolution in the past 5 years, 10 years, I would say that the integration into clinical practice is quite variable. So I think in the next 5 years, we'll see more and more integrations into lung cancer screening practices, both for nodule detection, lung meds assignment, and perhaps generative AI in terms of NLP and nodule tracking. I think 5 years is critical from, enterprise perspective, because either one or probably my guess is several, but definitely not dozens or 20, 30 products. Maybe a couple strongest products will emerge as the dominant ones in the field that most medical practices will start integrating. So I'm interested to see what companies and what types of products will be most well integrated in those timeframes.
Yeah, I think I'm seeing a lot, and just kind of surveilling all the FDA submissions. I'm seeing a lot of similarity in the performance metrics, especially for the newcomers. And I think there's going to be kind of one thing that comes out of that is that we're going to see a big shift towards like usability and interface, and how well does this integrate into the system? How well
into the
does it?
workflow.
Yeah, exactly. And how well is this kind of tuned to kind of operate in harmony with the user? And I think we've kind of moved away from the put a bunch of data in, label it, and then get a model. I think people have kind of figured that part out, and now it's just a game of, okay, how many people can we sign up to give us data, and how quickly can we label this? And where I've seen a lot of the innovation is just what is the interface, and so that's a different problem. In terms of the 5 years, I think with ChatGPT, and I've kind of shifted my predictions on the adoption of AI with the kind of the popularization of ChatGPT. Is like ChatGPT was the other half of the equation, where models were speaking in a foreign language that really couldn't be adapted to how we interface in the health system. And now with GPT, I think there's like, oh my gosh, it's now they can speak our language. And now I think the word is out. The golden goose here is being able to generate these radiology reports. And I guess a little bit of a saving grace is that we kind of played a trick on AI developers and put them into chest X-rays, which has some of the highest inter-observer variability that exists. And so we were in this like really weird territory where like they went because they AI companies are going because that's the largest data set, but it's also the noisiest data set. So I think people are kind of gradually figuring this out. But yeah, I think maybe like a 20% shot of those kind of like full chest radiograph dictations, but that's vastly increased with ChatGPT.
Yeah, I have some ideas. We need another hour to discuss, but I would say that if you wanted my opinion, in 5 years, it was like you said it well. The other half of the equation that was missing for me in my mind was the language part. We had NLP, but like now we have ChatGPT. Like the EMR is available, now to interpret. Yeah, we were just overloaded with data, right? Like there's just too much data. It was killing us, and killing patient care. And so I think that's for me. The dictation is really where I see things changing in the next 5 years. Just I see our role as being just much more intellectual. Like, oh yeah, AI tracked these 4 nodules. These 4, all the volumes are in my report, right? They're in my report now. And I'm going to say, okay, this one I think is needs to be modified a little bit, right? Like I'm going to use my brain there. That's it. Now that's going to be our job. Like that's what I see happening very rapidly, because I think dictation is stagnant. Rich text moving into the EMR has been like no change for too long, and that's where we're going to see a lot of stuff is with these large language modules, which let's be honest, we're super early on.
Yeah,
so
totally agree. Really exciting.
Well, this was
absolutely
really awesome. I'm so glad to get to know you both and like listen to your thoughts, because there's no question you guys are right on the pulse of the latest trends. And it was a great webinar. It just flew by, the whole hour, and we didn't even finish all our topics. So that was great. Thank you guys so much for your time and your brain power and contributions. Really appreciate it.
This is great.
Thank you for the discussion.
Yeah, likewise.
Okay.
Thank you everyone for attending.